Well, good afternoon, everyone. My name is Mark Skidmore. I'm the director of the North Central Regional Center for Rural Development. Welcome to the first of a webinar series entitled Combating Opioids. And this webinar series is part of a Rural Health and Safety Education Grant, a USDA-funded activity. It's done in conjunction with Purdue University Extension, along with several other partners here in the North Central region. Our goal for doing, of the grant in general is to share information and best practices to prevent opioid misuse and abuse in rural counties, increase professional capacity to engage in health leadership in rural counties, increase access to new ideas and technologies related to opioid misuse and abuse in rural counties, increase public health knowledge and engage in health in the health system, and increase health literacy of opioid misuse or abuse in rural counties. We've got a series of a total of 8 webinars over the next year and a half, and at the end of this webinar we'll put out a save the date for the next webinar, which will be in January. And so today we have with us Michelle Sabizma. She is the Chief of Strategy and Development at Parkdale Center for Professionals. She has a long history working in business and development strategy, as well as serving on, for example, the Indiana Prescription Drug Abuse Task Force. So we're really pleased to have her lead off the webinar series with the topic entitled How the Opioid Crisis Impacts Individuals in Rural Communities. And so with that, I will also say that if you have a question that you would like to ask of Michelle, you can use the chat, and that's just down at the bottom of your screen there. So you can do that at any time, and then Michelle may answer them along the way as she's giving her presentation, or wait till the end. And then we'll have a little additional time for questions as well at the end. So with that, let me pass it on to Michelle. Michelle, thanks for being here.
Thank you for having me, and I'm really glad to see we have such a large number of participants in this webinar. Perfect. Sorry, there somebody needed to mute stuff. And this is obviously first of a series. And so what we're going to try to do today is touch on the basics of a number of issues, kind of how does this impact us from an individual and rural community standpoint across the board. If you are I just noticed somebody said they're having a hard time hearing. Let me see. I'm going to turn the volume up just a little bit more. I hope that helps. A little better? Much better. Oh, wonderful. So wonderful. We've already kicked off the webinar with interactivity in the chat, which is really helpful. And so I'm going to move on now to continue to talk. For many of you, from a generational standpoint, may remember the Follow the Bouncing Ball. So today we have Follow the Bouncing Pill to kind of talk and lead us through this dialogue. It will not be an extremely deep clinician-driven conversation. This is much more of a high level to kick off the webinar series, but I certainly hope that...
Michelle, I hate to interrupt you, but it looks like a few people are still having trouble hearing you. Can you turn up your volume some more?
All right. Is that any better? That's as high as it will go.
For me, it sounds fine. So hopefully can you bring your mic a little closer as well?
All right. I'm hoping that's better. I have one other option. I'm watching 1 second. Okay. So I'll speak as loudly as I possibly can. We have some learning objectives today. And that is to define an opioid. What exactly does that mean? So to describe how opioids impact the dimensions of health, how the impact of the opioid on community, describe the impact of the opioids on the community. Why do we consider this a crisis? How do we identify addiction? And then how can we potentially adjust some of our language to help reduce the stigma and tie the addictions component to the stigma-free focus? So first of all, let's talk about what drugs are most often abused, because one of the things that we want to keep in mind as well is we say opioid epidemic, and that covers a lot of ground, but we, in a systemic way, have an attitude towards drug abuse and misuse that's a little bit challenging. So we have pain relievers, which are also known as painkillers. We also have within those that covers a great deal. So opioid or narcotic pain relievers that are sold to share. Sometimes they're shared, sometimes they're sold to get high. Drug pain, dull pain, or changing mood. We have central nervous system depressants, or sometimes we just call those depressants, and that can include alcohol. But from a prescription standpoint, those are used to treat anxiety or sleep disorders. They're also used to relax or wind down, or interestingly enough, sometimes come back down after stimulant use. So these factors, they all kind of play together. So stimulants, we are aware, are used for attention deficit disorder, narcolepsy, and weight loss. There's a number of reasons that you may use legitimate purposes for stimulants. But sometimes in a misuse standpoint, they are used to stay awake or come back up after depressants. So what we learn in this process is, while we hear a lot about opioids and the opioid crisis, many times that crisis is tied to the use of a number of other things that are getting just a little bit less airplay, but they're all very intertwined. We have a quick poll. Who has felt an impact in our community beyond the local news coverage? So we're going to let our participants answer this question really quickly and just kind of see. So as we're seeing, we have a little bit of a split. The predominance is that people have. I'll be interested to see what this tallies out to as it completes. But many times, the challenge with this is we don't believe it's a problem because it may be that it is a crisis or an epidemic, but it hasn't personally touched us. So it feels surreal. It doesn't feel like it's quite hit home yet. And we're going to talk about why, in some instances, you may not necessarily know there's a problem right underneath your nose. So we'll come back and see, but it looks like we have about 63% and counting on this one. So I'm trying to move our poll here so we can move through the slides. Thanks. We have a really interesting thing that happens that many times gets very, very underreported, and that is the high risk of a combination of what we often hear referred to as an unholy trinity. It is the opioid pain reliever combined with a muscle relaxant and a benzodiazepine, and I'm going to bring that down to a more common language here in just a second. You mix a painkiller with a muscle relaxer, and you add any kind of depressant, particularly benzodiazepines, but that pretty much, because a benzodiazepine is a central nervous system depressant, what happens is people get the highest high they've ever gotten, but many times there's a great euphoria, but also the highest risk of death. So we have a really challenging mix here. So people basically will oftentimes just overdose without intending to. Sometimes we get into unintentional overdoses that people they weren't expecting because they didn't have any kind of addiction issue that happened. It just so happened that those three dangerous drugs combined caused a great problem. And so let me tell you a little story about how this might happen. Suppose I'm in a really bad car accident, and I have a great deal of pain and muscle tension that occurs from that car accident. And I go see my physician and I say, I'm hurting, I need something. They prescribe an opioid for me. It's a short-term prescription. It's not any big deal. They also gave me a Flexeril as a muscle relaxant because my muscles were really tight. But I didn't tell my psychiatrist, who I go to see because I'm having a tremendous amount of anxiety, that I'm on a muscle relaxant and a pain reliever. And if that psychiatrist doesn't do a prescription drug monitoring check on my prescription history, it is possible I could be prescribed 3 items that should never be prescribed together. It is also possible that to items 1 and 2, I may add several glasses of wine to self-medicate for my own anxiety and create the same type of effect. And it's a very dangerous thing, and it can very easily lead to unintentional overdose. And so not everybody we talk about are we talking about intentional overdoses or overdoses that necessarily had to do with illegal or nefarious use. So one thing is really important that we talk about when we talk about opioids is opioids means multiple different, there's a number of different drugs that may be opioids. But we often hear opiate, an opioid, and for the purposes of common language, they have become very, very interchangeable. And the news media does not take time to dive down and do a big differentiation between whether it's an opiate or an opioid. So when we hear the opioid crisis referred to, we are talking absolutely about all opioids and opiates, and that includes heroin, that includes oxycodone, that includes hydrocodone, that includes any of the tramadol, even the lower level opioids, but any number of those drugs can be impacted very dramatically when added to other drugs. So we have a high abuse potential with any drug. It doesn't really matter which one it is. And we hear people say things like, oh, it was the worst headache I ever had, and it was a holiday, and my sister gave me just a pain pill. It wasn't any big deal. Or I was testing to see if he would do as well as his brother did when he had ADD medication, because his brother has ADD, and I'm not sure if he does. So someone else may say, well, he threw out his back shoveling snow, and the neighbor just gave him one pill. None of this was nefarious intention. Too bad that that headache that was the worst headache that ever happened for someone's sister was actually an untreated aneurysm. This is why we don't hand our prescriptions to other people. Too bad that you just taught your child when you were testing out his brother's ADD medication that it's okay to share prescriptions between individuals. And for that neighbor that threw out their back, the script was bought by an unsavory discount online pharmacy, and it was washed down with a beer, and it had toxic levels of something in it. We really don't always know. So abuse comes in many forms, sometimes very unintentionally. We have this picture of addiction that starts in an alley because that is what the masses were taught when we were younger, was that drugs came from somebody bad in an alley. We never ever were taught, hey, drugs come from your doctor's office, and you need to be thinking about those too in terms of addiction. It took years for us to catch up and understand that that's exactly what can happen. So let's talk about opioid use versus having a high from an opioid versus a low, because I think this tells a really important story. Long term, the side effects of opioid use long term can be nausea, vomiting, bone and muscle pain, which is fascinating because nobody ever thinks, why would I get a pain pill whose side effect can be pain? But the truth of the matter is, it is a side effect of an opioid in many instances. The other thing is collapsed veins, and that only happens when you're doing IV drug use. And so most people think, well, I might take a pill. I would take a Vicodin if I got my wisdom teeth pulled, but I would never do heroin. And so let me explain to you how this process kind of continues on here. One pill becomes a number of pills, and a number of pills for some people can really trigger. You start out with a legitimate prescription, and then you have your legitimate prescription and you run out, and you start maybe looking for other alternatives That may mean someone that you know has a prescription for something else that was similar. Maybe they had a few more that they never used and you knew that they worked. So instead of going back to the doctor, you say, I'll just finish out your prescription. It was, I'll just take the rest of my spouse's prescription. But the prescription suddenly becomes a little less about what the doctor wrote, and a little bit more about solving the pain dilemma. And remember, there's sometimes long-term bone and muscle pain can be caused by an opioid, so begins to become very difficult to discern what is pain that needs to be solved by it and what is pain that may in fact come from it. So then what happens is some individuals may seek an opportunity to get it into their bloodstream much quicker because they are in great pain and they are looking for that pain to go away as fast as possible. And when I say pain, I would also include the nausea and vomiting at this point, because I am now trying to take a pill at work to make sure that I can absolutely function as fast as possible and no one notices that I am losing it as an individual, because I'm in a world of hurt. So I crush up that pill and I snort it. Now, that's not an option really when it says on the side of the prescription bottle, but unfortunately that's what happens for a lot of people who have succumbed to that cycle of being hooked on that medication, becoming chemically dependent. Long term, you're looking for anything to keep you from looking like our guest of honor here in this picture in the bathroom. And then at that point in time, sometimes people will turn to keep from having to be in that state to the needle, which is where a lot of people that will tell you, those in treatment will tell you, I never thought I would get to that point. It was always pills. It was always, other things, but then suddenly it becomes worse. And then I have something that I like to, I don't like to refer to, but I refer to it as emotion burnout. This isn't emotional burnout. This is my emotions as an individual who may become compromised, to, sorry, I'm reading the chat questions as they come in as well. My emotions may have been so compromised by opioids. This is also a long-term challenge. There is no feeling of euphoria left. You're not getting high to get euphoric. At this point, you're getting high, as we like to say, just to prevent feeling as low as you possibly could physically. And then emotionally, you're completely killing your ability to emotionally feel anything, even positive. And one of our participants said it might also be easier to access street drugs like heroin. Yes, that is unfortunately a byproduct of what we're trying to do is right the ship as a society, because we got very okay with writing prescriptions as fast as people would have a need for pain, and then we weren't necessarily addressing the fact that people were hooked, and so there's a tendency to we're righting the ship in terms of doing a better job of not writing as many prescriptions. But what we didn't really do is create a good system to help rectify all those in this state, before they are in need of some kind of withdrawal. And what they have convinced themselves is the only way to get out of that cycle is to continue adding more drugs to the cycle. At that point, the only way to truly get out of the cycle is to allow yourself to go through the withdrawal. And I was once told by someone, and I thought this was a very insightful and enlightening comment for me at that point in time as an outsider to the topic, that with alcohol withdrawal, you can die from withdrawal. With opioid withdrawal, you want to die during withdrawal. It's very different. There's a high risk for detox, for an alcohol, someone who is addicted to alcohol as they detox, whereas the opioid withdrawal is just the worst possible experience of going through withdrawal that you could imagine. And so people tend to give up when they try on their own. Oh, I'm going to go ahead and just give up. I'm clearly in pain, so I must need a painkiller to solve this. And they keep getting back on that cycle. So as I pointed out earlier, overdose can come in many methods. There's a number of people who make that the accidental overdose combinations from prescription drugs. That's an oversight issue. They must, our physicians need to test our prescription drug monitoring systems. They're called something different in each state, but they're for the most part, they're all interacting. We've come a long way in terms of crossing state lines and not having somebody leaving one state and going to another to drug shop, to doctor shop. But the patient may not always disclose all the prior prescriptions that they're on. We have a lot of complexities. We have dentists and pain clinics and psychiatric doctors and all sorts of different doctors. And so that's also very worth noting, is that if a patient doesn't disclose, it's that much more important than a physician do due diligence. But they can only do due diligence if, in fact, that drug is in the system. So if they're taking someone else's medication that doesn't belong to them, it's not going to be in the system for the physician to see. And so that one or more prescriptions of someone else's can really be, I was just asked about ordering from other countries, and we're going to talk about that as well, but that absolutely happens too. Over country lines is an issue. So ordering medication from Canada or from China and whatnot. So we have illegal prescription and street drug combinations. This is often they're obtained illegally at this point from pill mills, from dealers, from legitimate pharmacies, or stolen. But stolen has a whole host of subcategories. Stolen from individuals, stolen from for healthcare facilities who don't have good diversion practices. And also stolen from even showing your house through a real estate transaction. If you're not locking down your medication, you're really letting yourself be vulnerable, and people don't give a lot of thought to this. I am getting a lot of questions. So what I will tell you is, to the degree that I can stay focused on the presentation well and answer those questions as we go, I will do so. But if at the end I have not answered your question, I'm gonna try to catch back up on some of those. So please don't be offended if I didn't answer right away. Overdose, it's often daily news. These are not all addiction-based issues. As we mentioned, many times they can simply be a bad combination of medication. The other challenge with overdose that we have to contend with is every single time someone uses naloxone and is sent to an ER, it is up to that ER whether they opt to do a tox screen or not. So it's really easy for an overdose to quickly be labeled heroin in every instance, and it may not always, in fact, be heroin. And so what we're going to have to watch for as a society are ways that we can implement better checks and balances when we have overdose issues. Now, many people have asked this question. How is it possible that we are having this issue, quote unquote, under a doctor's care? Because a doctor's job is to make sure that they take care of us. First, to do no harm, right? That's the big quote. Well, several things have transpired. One of those is we had in the mid 90s, we had a great number of responses to an article that was written about how irresponsible it was not to treat pain. And pain became referred to at that point in time as the fifth vital sign. And that some people are underestimating the power of ibuprofen and acetaminophen. This is an absolute true statement. But also we're very conditioned. If you recall ever having been to the ER for I recall I took my daughter once upon a time to the ER. She had broken her arm and she was young, and that was the first question. It was, for the understanding of common language, universal language, understanding literacy rates, all of these aspects, they've begun to use, or they have used for quite some time, I guess, actually now, our little smiley face rating. But when you present that as a hospital, as the very first question is, what is your pain? There becomes an association that is the priority for treating the pain And we also have a need to treat the origin of the symptoms, and that's extremely important not to lose sight of as a patient. But it's not something, patients aren't trained, and we're certainly not trained to be patient as a society. So we have some disconnects in the system. Addiction risks vary greatly. Um, Symptoms or pain treatment expectation does change how a physician may handle the situation. Um, Evolution of the problem. The drugs have gotten stronger. More people have gotten prescriptions. It's a bad mix. And pain is subjective. I always like to ask people to think about, if I ask you to describe pleasure, you would have a very difficult time describing pleasure because it's a subjective item. So is pain. Everybody's pain tolerance is different. And withdrawal leads to alternatives. For some people, the withdrawal from medication is causing pain, and pain has a tie to our anxiety, and anxiety mixes. You've got the mental health and the physical health mixed there. That makes it really difficult to treat patients universally, but not exactly the same. And so tolerance can build. Each individual has a different tolerance to things. One other problem in the process is that um, we also have a difference in education from generation to generation with physicians. Once upon a time, there was a belief that if you were using an opioid to treat pain, it was impossible to become addicted. We know now that is absolutely not true. Um, and so I think I have an important question to ask. I have another poll, and that was, do you remember when more frequently the use for the word opioids wasn't opioids, it was narcotics? Okay, we have a lot, and it's interesting also that when I have been involved with the older generation, many times they've heard millions of what seems to be millions of news reports about opioids, hundreds of news reports about opioids, and didn't even know that a narcotic and an opioid were the same thing. So it has a great deal to do with generation and education. So not only do we have a disconnect when it comes to how our physicians were educated, our our public conversation is what educates the public in many ways. And so if people don't say painkillers, opioids are narcotics to an older audience, they may not realize that they've been talking about this is the same topic. Okay, so we're going to move on past that poll. We've got a pretty good thank you. And now let's talk about the dimensions of health. I'm Our mental well-being is tied to our health. There's no doubt about it. And as an individual, we have a number of aspects here. We have our emotional well-being, and as we know that opioids do not do wonderful things for our emotions. It numbs you, very much so. Any kind of excessive use of any kind of drug can have an impact, a psychological impact on you. It can compromise you intellectually. We know this. And maybe this seems like it's stating the obvious to some degree, but I think it's important that we look at all of these aspects. Think about opioids long term on your physical well being. Obviously, if anybody's going to be sick from taking medication or a drug, then it has an impact. Socio or cultural. Do you, most of you, we don't have to do a poll to know this, but most of us, I think, would say without question that the attitude in the United States, socially and culturally, is pro painkiller compared to many of the other countries. We supply the majority of the world's opioid use in the United States. That tells us something. Environmentally, for a very long time, the government websites even said two different things. The DEA said, flush your medications. The EPA said, don't flush your medications. And so we have to get on a consistent page about this, because putting drugs back into our water supply is not going to benefit anyone's health. Occupationally, we are hearing a tremendous amount of workforce compromise, skills gaps that are created simply because I can't find enough people who have the skills for the job I need that can pass the drug test that's expected of my insurance company. If I don't do drug testing, my insurance company is going to raise my rates so much that I have to lay off a third of my workforce. It's a vicious circle. And then, of course, spiritually, if you don't have those other aspects to your well-being, it's very difficult to connect in a spiritual sense. So, very much tied to an emotional side. So we know that the dimensions of health are greatly impacted by the opioid crisis. We also know from an addiction standpoint, 1 in 10 people in the United States needs help. And that's a pretty long-standing statistic. So if 1 in 10 people need help, then what is the disconnect? Why are we not getting more help? Well, a great deal of the problem comes from a massive lack of mental health trained individuals. 66% of individuals who have an addiction issue also have a mental health disorder of some sort. And so that means that we have a lot of need for cognitive behavioral therapy. There's a lot of trauma that these individuals have gone through. And in fact, the concept of being addicted in and of itself is rather traumatic. Um, it's really hard. People struggle with how do you handle somebody who has an addiction? Well, first you have to be able to identify it. And most of the time it is in fact hidden in plain sight. We have a picture of what we refer to as that under the bridge type of individual, that disheveled and non-functioning individual. But many times these individuals are working right alongside us. It doesn't matter whether this is a healthcare facility or if it is an EMS worker or if it's a teacher, they're male or female. You can pretty much put rule of thumb, approximately 10% of any given room has an issue. There are approximately 100 between our hosts, our presenters, and our participants. We have 100 here. 10% statistically have some sort of addictive component going on. And so we're trying to better understand and appreciate that addiction is chronic, it's progressive, it is many and most instances characterized by denial, and it's sometimes difficult to spot. And so it's also very important that we point out that it's very hard to keep it stigma free. If you read any news article and look at the comments that are made in social media in those news articles about anyone that has had an overdose or an accident, I mean, the comments are very often vile. And so it is really difficult to keep this addiction stigma free. But I can tell you in the treatment world, usually the individuals carry more guilt and self-stigma because they have gone through what they've gone through than we could ever throw at them. There's plenty of guilt and challenge to go around for these individuals. So just being understanding of them is very important. It is a disease model, and this is a medical fact that our society, as a general rule, does not understand very well. If I say, oh, my neighbor has cancer, we immediately rally. Oh, desire for recovery. Behaviors can intensify cancer. So maybe you shouldn't smoke. We don't want you to, get lung cancer. We don't, we heard you have lung cancer. You got to quit smoking. Goal remission. That's the goal there. And then there's a chance of recurrence. We call that, you're in remission, but it can recur. Addiction is the same exact descriptors. These people have a desire for recovery. Behaviors can intensify that. Yes, absolutely. Alcohol intensifies is an addictive behavior. However, not everybody that drinks alcohol is going to become an addict, and an addict, or excuse me, going to become addicted. And someone who is addicted may, in fact, have every desire not to be. It just changes behaviors, intensify it, but it's not a guarantee that just because you drink frequently that you're going to have an addiction. There are differences. The goal for getting rid of cancer is remission, for getting rid of or to manage addiction is the goal of sobriety. But there is always a chance of relapse. We know this. For those who have been through treatment, it's an important part of their treatment is to understand the risk of relapse and what those triggers look like. Um, Super important. Most people don't get treatment voluntarily. This means they have to admit that they have an issue. They're often, as I mentioned, very plagued with shame or guilt. There's a fear of stigma from others. It's really fascinating for me I am not in recovery. That I am an ally. I like to refer to myself as an ally. But as soon as I mention to people that I work with a treatment facility, their immediate response is to check themselves. Did they order a drink? Is this their first drink at dinner? Is this their second? It's fascinating to me the body language that comes over. We do carry a stigma as a society. The system is very complicated. That is probably one of the biggest challenges that we have. We have a massive shortage of mental health trained individuals, and the system is complicated. Do you have private insurance? Do you have Medicare? Do you have Medicaid? Do you need to be detoxed? Most people think, layman wise, think inpatient means that they are checked in for 30 days stay, but that's not in fact how inpatient works anymore. And so there's a massive complication in how we describe things within the system. Um, and I have a question. What's the recommendation for tapering patients off of opioids? I am not a clinician. I would be happy to put you in touch with the clinician. We work on the American Society of Addiction Medicine model. That's a great website to take a look at. They can probably give you a little bit more information about titrating someone. I don't feel that this would be an appropriate place for me to tell you my speculation because it's not the right thing for me to do. But it is an important thing not to do lightly or without a qualified individual involved in the process. So thank you for the question. I'm sorry I can't answer it in a more comprehensive way. But the other reasons why people don't get treatment voluntarily is they simply don't know how. There is a belief that it's going to be completely expensive and unattainable, and they don't even know where to go. Most treatment centers are not so connected with other treatment centers that we can look up in an EMR and see how many available beds are available for detox in any given area. We are working on these improvements as a society, but we are not there. And there are barriers for many that are often, but many times people want to put up the barriers why they don't get the treatment. Well, it's expensive. And if you calculated how much an alcoholic may spend in alcohol in any given year, the treatment doesn't look as expensive as people think. But we also kind of have to come back to this concept of fear of stigma. If you have an issue, you may need to take time off of work. You may need to take family medical leave, or you may be working for a smaller facility that doesn't have that option. So you may have to address that, and that creates yet another reason that people, the stigma comes up. How is my boss or my employer going to take this if I tell them I think I need some help? But what is the cost of no treatment is probably a more important question. Treatment with lack of treatment, we see an awful lot of issues. Nobody wants to turn on the news and see someone who's overdosed with a needle in their arm in the middle of an interstate with their children in the back seat. It is just the worst possible concept. But this is where someone has gotten to the point where they're numb to their feelings. One of the big challenges that they're experiencing in a number of states is people who have lost their children into foster care because of their behaviors, and they get clean and they don't necessarily want to get their children back right away. And that is, for someone who's maternal or paternal, that's an incomprehensible thought. But what we're dealing with here is the numbness, that emotional burnout, that emotion burnout that we talked about. They are not resonating with their children at this point. And so that may take some time for that neuroplasticity to cause that to come back. So it's a horrible thought, but it is the reality of what's happening in rural America in a number of places. What I have here is if you take a look up in the top corner on the left-hand side, this is a National Safety Council website. Community Health Network, as an example, it's just here's an example of an organization. It's a wonderful organization serving the community in a health capacity. This organization has 13,000 employees. This questionnaire at nationalsafetycouncil.org/drugs at work is a phenomenal resource. You answer 3 questions, and it gives you a very comprehensive report of what the cost of not treating any behaviors with regards to drug and alcohol in your workplace can be. And so it's a wonderful thing. It's a wonderful tool to promote to help businesses to understand the importance of education. Another website, we mentioned what happens when you purchase pharmaceuticals over country lines, is we don't necessarily always know where those pharmacies are, the legitimacy level. Just because of their location doesn't give us any guarantee of how legitimate they are. And so one of the resources that we have is a website, and this is not a mistake. It's called AwareRx, stands for Aware Pharmacy, or prescription, awarerx.pharmacy. If you are at a website that is ending in .pharmacy, it has been vetted and is in fact designated a part of the Aware Prescription Drug Safety Program resources. And so our National Pharmacy Association is supporting the promotion of healthy pharmacies if you're going to purchase online. So many of our physicians will hear the concerns about that patients have about not having good access to pharmacy pills at a decent rate, and even suggest that they go online. But it is a responsible thing to do. If you're going to suggest someone go online, either give them a website or teach them to look for this .pharmacy domain. So if you see the .pharmacy domain, which we don't see it a whole lot because it's not a .com or a .org like we see most websites, but if you see .pharmacy domain, it's in fact legitimate. So they also have a drug disposal locator. This was part of the contributing factor for a very long time to opioids, is that everybody could get them, but nobody could get rid of them because there weren't enough legitimate destruction sites. And the DEA regulations are very complex, and they don't allow you just to give them back to the pharmacy. So this .pharmacy is this website verification program. I just want to make sure I'm promoting it adequately because it is an incredibly helpful resource, especially for those of you in rural areas who don't have a real tremendous amount of pharmacy options. It's a great thing to promote. The other thing that's really important is that we don't get sucked in. A lot of people out there giving out bad advice. You can't believe everything that you're told. It's really important that you get a second opinion and that you ask your local pharmacist. A pharmacist's job isn't just to hand you the pills. There's a reason why they ask us to sign an initial that we're offered advice. It's because we want the world to know that your pharmacist is there for good prescriptive advice. So those 2 things are very important to remember. The other thing is prescriptions are prescription for a reason. We have to take them seriously, and in order to do that, we have to model good behavior. If our children see us looking through our medicine chests for anything random and taking old prescriptions or taking prescriptions that belong to other people, then we are never going to change that mentality. That little brown amber bottle is a prescription for a reason. It was not decided that it was safe to be over the counter. And so we have to really be careful that we don't just teach our kids that prescriptions are prescriptions because they came with insurance benefits. And that's really, really difficult sometimes for us to let go of, is we think that sometimes as grown adults. So why would it be any surprise to our children? The other thing that is important, and I admittedly was a little distracted by the sound quality being problematic when we first started, and as our introductory slide, so please forgive me that I didn't point this out earlier, but stimulants are being thoroughly abused by our children, our college-age students and our high school students, and there's a couple of reasons why this has happened. One of them is that we had a false belief for a very long time that stimulants would actually make your test scores improve. And that's not true. Studies have shown otherwise. They do make you sit still and focus better if you have ADD. not if you do not. But it is a challenge because they got a really thorough promotion by an era of parents who liked children that focused and sat still and did well in terms of listening. And that was a bit of a challenge. So we taught our children that prescriptions for drugs can actually make them a better person if we didn't properly have those discussions with them. When a child who's taking a stimulant for an ADD isn't, if you don't explain to them why and what it's doing, and your response as a parent is just take it, it'll make you do better, then you have taught your child that in fact they are not as good without a pill. And so we've got patterns that we have to break, cycles that we need to break in our society, and those are very much one of them. The other challenge is that if you add a stimulant to in the college environments, we've heard this a lot. Stimulants, in fact, are very promoted because while you can stay up and cram, if you take your a number of stimulants, then you can sleep. You don't have to sleep as soon, so you can cram for those exams that you didn't study for. If you mix a stimulant with alcohol, the reaction for many is that less alcohol is required to get a buzz, as the college kids will promote. And so that freshman 15 that everybody's worried about getting, they get into this cycle of, hey, it'll help you lose weight, it will make your buzz better. We hear all of these comments that are promoted right or wrong by college students, and we have a whole host of college students that are suddenly trying to get an ADD diagnosis from their healthcare clinic, and they've taught each other that if they use the FERPA forms, the parents will never even find out. It'll just look like a college activity fee on your tuition. So we've got a real gap in this teaching of our children that needs to be closed tightly. We must help an addicted loved one or colleague, and that's difficult. We have to learn how to help these individuals who have a challenge. We have to offer support and a belief that to them that they are understood, but they are not just their issue. In other words, if I have someone that comes to me and says, hey, I have a problem, I'm not going to suddenly see them as only their problem for the rest of their life. I do believe that you are more than just your issue, if you will. Somebody just pointed out and said that we're seeing the stimulant abuse in junior high and high school for sports. Yes, that is also true. And painkillers, they like to get right back out on the field as fast as possible, and it may not be always in their best interest. So don't expect that you alone can help them. It is not your job to save an individual all alone. You need to help them get resources. Don't try to figure out what the origin of the blame for the problem is either. The source of the addiction can be very complex, and it's not your job to try to eliminate the source or to find a blame. It's to just try to help support them. Try to find a reputable treatment center for advice, and you may find the best way to do this is to locate or attend an Al-Anon meeting, and then you'll meet other people who have better understand that disease of addiction and who have walked the walk of trying to support a loved one or a colleague, and that can be very helpful. And so we want to make sure that that story has a happy ending and not a tragic one. Best long-term practice, as we mentioned, teach our children well, model good behavior, understand that stigma-free is critical for those who want to get help. It's really great to say we support stigma-free, but everybody's got an addiction. That's not necessarily true, and it's not true. And it's not necessarily helping to support those who really want to break the cycle. It's a really difficult thing to watch somebody who has really been consumed by an addiction, and then they're trying so desperately to get themselves out of that, and they are trying to get help, and everybody's looking down on them the whole time. It does not make them want to make the effort. It takes a lot. We need to keep educating a great deal, and thank you for being part of this education. That's really important. One more piece that can be really helpful in reducing the stigma is say this, not that. So this is a really great slide put together by the National Council for Behavioral Health. We try, and it becomes very ingrained as a human. What we hear is what we're exposed to, but We try to say person with a substance use disorder as opposed to an addict, a junkie, or a druggie. It does help. It's just creates a more trusting environment for somebody to be able to believe that they can come to you and talk if you don't seem as if you're quite so judging in how you language things. A person living in recovery as opposed to an ex-addict. A person with an addiction is battling or suffering from an addiction, and that is it's a very true statement. They are battling an addiction. It is I often tell people, if you hold your breath for a long time, and then I said, okay, you can breathe again. Did you make a choice to breathe? And we don't choose to breathe. Breathing is an involuntary reflex. We chose to breathe in that moment. But the truth of the matter is, addiction is not something people chose. The behaviors that may trigger it may have been part of their decision, but the decision that they have this constant intensive craving all along every day is not their choice. How they react to that craving is part of their choice. Um, More stigma, say this, not that. Choose not to at this point instead of being non-compliant or bombed out, you failed. Medication is a treatment. Medication is a treatment tool versus medication is a crutch. Um, Maybe we say have a setback instead of relapsed. That one's kind of, it depends on who we're talking to as to how they take that. It's a bit of a challenge. Maintained recovery versus stayed clean. And the reason that we say that is, as opposed to the alternative of staying clean, is that if you're addicted, you're dirty, and so we'd like to say maintain their recovery. And having a positive drug screen versus a dirty drug screen, it can make the difference. So. Got a couple thank yous. Thank you. Some extra resources. I've identified some websites and some organizations that may be useful that I referred to in this presentation. The most important thing is that you know that no one should tackle this issue alone, and that we're here for you if you need that. And now I'm going to ask if there are any more questions, and I'm going to try to scroll back through. But if you would, please send, if you have an additional question that I have not already answered, send it again. It's perfectly okay. They were coming through pretty rapid there for a minute. And we would ask that also before you leave that you fill out the summary evaluation. I think that's very helpful for us. And I'm really sorry about the sound. I really don't. I apologize. And you're welcome.
Thank you, Michelle. So you can see here that we have the summary evaluation. We really appreciate your feedback. And in addition to that, I've put a little posting up on our next webinar, which is entitled Recognition and Stigma in Prescription Drug Abuse and Alcohol Abuse. And Robert Shupp from Michigan State University will be presenting that on January 17th at 12:30 p.m. Eastern Time. And so we'll be sending out updates and notices of the webinars as we move on. Let's see here. Michelle, do you have any questions that pop up that you want to try to tackle right now?
Somebody asked about upcoming webinars, which I think that we've got that save the date on the screen. An email notification of future webinars, I would say yes, that is likely. Is that fair to say, Mark?
Oh yeah, we'll send out updates as the webinars come on, and if you're not on the list, you can contact us. I'm going to type in. Hang on just one moment. I'll type in an email that you can contact us at. Just one moment.
Okay.
I'll
also type my email address in here too.
Yeah. So I've just typed it in and saved the date for the next webinar. Scott Loveridge, by the way, I want to add that in addition to Robert Shupp, Scott Loveridge, it will also be presenting some of this work. It's based on a nationally representative sample of prescription drug and alcohol abuse literacy regarding those issues. Okay, maybe
webinars are going to be capped at 200 participants. I think they capped at 100, and we hit our capacity. So
yes, we did, and so we want to send out an apology to those who weren't able to get on. This was so well attended that we hit our cap, and we didn't realize that we were going to hit that cap. So we'll get that expanded for the next time. We will also have this record. We recorded it, and it'll all be available on YouTube and posted shortly. And we'll send out an email when that is done.
And thank you all for your patience as we worked through the sound bug, and thank you for your very nice comments. And if anyone wishes to follow up directly, I'm happy to do that. And I'm really excited to see so much interest in this. As a launching point for the future, probably more continue to become more in depth as these continue to grow. Also a question, can you address the growing addiction in seniors? I have a really interesting observation about seniors. I'm glad you asked that question, Jody. Seniors are of an era that you do not question, many times, you do not question authority. It's considered disrespectful. So if a doctor gives you a prescription and you do not follow that doctor's orders completely, you have questioned, in a sense, that physician's orders and or their authority. And so what will happen is many times, even though they aren't necessarily, we're not real clear when we say as needed for pain, the person feels if the doctor wrote it, they must have believed they needed to take it, so they will take it all. And then also we have a big challenge because with senior care, sometimes the Medicare process is very complex. They see multiple doctors for multiple different reasons, and those have gotten mixed between. The information is not necessarily always carried. So there's a few compounding reasons, but I would say predominantly, I believe that there's a great number of seniors that simply do what they're told and don't question authority, and it may not be in their best interest to take 30 days of pain medication. Since the medication attitudes from a physician standpoint have changed some, I think we're seeing improvements in that.
Well, maybe since we're just about out of time here, maybe this is a good spot to stop. And again, thank you so much, Michelle, for a great webinar and sharing all this great information. I really appreciate your time.
And that save the date is January 17th at 12:30 Eastern Time.
Yes. Okay, everyone, thank you very much for sharing your time with us, and we'll see you next time. Have a good afternoon.
Bye-bye.